Start now.
Yes, please.
Good evening. अपने आप आ रहा slide show ये तो. Today we are going to discuss. I hope you all can hear me.
Loud and clear.
So today we are going to discuss evaluation of thyroid swelling and management. The evaluation is the more important part because after that only management starts. But today in today's talk, the management, only outline of management will be considered, and for full management we can take some other class. So today, but a complete outline of evaluation and management will be covered today. So you know thyroid is an important endocrine gland, and you can see a thyroid picture in background. It is just there to show you the relations of thyroid gland, where it is situated, the upper extent on the oblique line of thyroid cartilage. This is pyramidal lobe. This is the right and left lobes, isthmus, relationship with the carotid sheath, relationship with the trachea, from where it starts, and both the lobes, the relation with the vessels, and because everything is important. So thyroid problems are quite common, and sometimes incidentally we find a thyroid swelling, which is known as incidentaloma, may be asymptomatic. And for evaluation, we must start, the most important thing is history. After taking demographic details of the patient, a detailed history is to be taken. And aim of history clinical examination, that is evaluation, is to know the changes in anatomy and physiology. That is, physiology means because thyroid is functioning, secreting T3 and T4. So if there's a change in the function, it can lead to hypothyroidism or hypothyroidism. And there are certain points in history which can give you an idea about whether the thyroid is functioning normally, hypo, less function, or it is functioning over, that is hyperthyroidism. And now, because there is a swelling in the thyroid, as we are discussing evaluation of a thyroid swelling, changes in the anatomical relations, relation to trachea is there, relation to esophagus is there, which is behind the trachea, then in the tracheoesophageal groove nerve is there, then carotid sheath is there. Because of these relations, there may be certain symptomatology, there may be certain pressure symptoms, or sometimes pain. An indication of pain, or when pain is there, it may point towards an inflammatory pathology or sometimes a fast-growing aggressive cancer like anaplastic. Pain may be there in suppurative pathologies, which may be rare. So presence of pain may point towards certain pathologies of thyroid gland. It is very important to take history of menstruation, menstrual irregularities in young females, mostly in hyperthyroidism. There's oligomenorrhea or amenorrhea, and in hypo it is usually polymenorrhea or menorrhagia. So it's because most of the patients of thyroid, they are females, young females, and therefore menstrual irregularities give an idea whether thyroid, there's a disturbance in thyroid function. More important than these is to decide by evaluation whether it is a benign or malignant lesion, whether it is a benign or malignant lesion. And also history can give some idea about if you take detailed history. Next. So after taking detailed history, we all know signs, symptoms of hypothyroidism and hyperthyroidism, and from the history we'll know that. Then there are other things in history which we discussed. The general examination, besides other points of general examination, pulse, icterus, cyanosis, clubbing, etc. There are certain important points whenever you are examining a thyroid case and you are doing a general examination. Besides build, hyper or hypo. In hypo, there's a weight gain. In hyper, there's a weight loss. Then pulse, sleeping pulse rate or resting pulse rate. If it is high, it is in hypothyroidism, and a bradycardia is in hypo. So signs and symptoms of hypo, other signs and symptoms of hypo or hyperthyroidism. It is very important to know eye signs, because in a toxic hyperthyroidism or Graves' disease, which is in primary hyperthyrotoxicosis or secondary, in primary there are definite eye signs, Stelweig signs, Joffrey signs, Mobius sign. And in secondary thyrotoxicosis, the brunt is on cardiovascular system. So by general examination, we can also know that. Then tremors in hyperthyroidism. So toxic. So from these points in general examination, we can differentiate between primary and secondary thyrotoxicosis. And also general examination, there are certain things which can give an idea whether there are metastases in neck or otherwise. There are certain things. So patient is to be examined in sitting position, comfortably sitting, moderately illuminated, and from patient is to be examined from front as well as from back. From front as well as back. On inspection, when just examining the patient from front, there's a method known as Pizzilo's method, in which patient clasps his hand behind his head over the occipital region and extends his hand like this. And in short, chubby necks, often the thyroid swelling, if it is not prominent, it becomes prominent. And in palpation, there's special method, Kreil's method, which is method when patient takes something, drinks water, and swallows, the thyroid swelling moves. And Lahey's method is when there's a unilateral lobar swelling, to know better idea, to have a better idea about that unilateral swelling, in which the patient with the finger, the examiner with the finger moves the lobe. For examining left, he moves the lobe from right to the left and it becomes more prominent, and otherwise. So in the sitting position, again, I'm saying from front as well as back, like Pizzilo's, you observe from the front. Kreil's also you do from the back, and Lahey's can from the front. So this examination helps us to know whether it's a diffuse swelling of the thyroid, whether it is a nodular swelling of the thyroid, it's a single nodule or multiple nodules, one lobe is involved, both lobes are involved. And mind it that all the points which we often take care when we examine any swelling in the neck or any other swelling, all the points are important in thyroid examination also. Then consistency, whether it is soft, whether it is cystic, whether it is firm, like hard in Riddle's thyroiditis, hard in malignancies. Relationship with surrounding structures, if it is on trachea, it may cause stridor or respiratory difficulty. Indirect pressure in esophagus, patient can complain of dysphagia. And nearby structures like carotid sheath, in which it may press, especially big malignant structures, big malignant thyroid can press over the carotid sheath. Then muscles, and especially if there is an involvement of skin, then the subcutaneous muscle, which is platysma, that can involve, and a puckering of skin at that area can give you an idea about the involvement of skin. Then lymph nodes in the neck. So this examination helps you to know all these characteristics of thyroid swelling. If the swelling is very big, thyroid swelling is very big, reaching the sternum, sometimes it may be retrosternal, going behind and beyond sternum. And in that case, Pemberton sign is done, in which Pemberton sign is positive, in which the patient lifts his hand above his head on both sides of the ear, higher than ear. And in that case, there will be flushing of face because of pressure on the thoracic vessels. Then laryngoscopy is done to know the condition of status of recurrent laryngeal nerve, because the recurrent laryngeal nerve in tracheoesophageal groove may get involved, and movement of vocal cords will give you an idea about the condition of or the status of recurrent laryngeal nerve. Now, after doing complete examination, different, as I told you, inspection, palpation, and then they say that percussion and auscultation is also done. And in auscultation, if it is a vascular tumor of the thyroid itself, or in Graves' disease, or the vessels below, deep to thyroid vessels, or any swelling is over a artery, then pulsations may be felt and auscultation may be done. In thyrotoxicosis or Graves' disease, a buoy can be auscultated over the thyroid swelling. Then we come to some basic investigations in thyroid. After doing examination, we do basic investigations, which are three. They are thyroid function tests, ultrasound, and FNSC. And how do we go about that? If we find, we have examined. So first is thyroid function. Thyroid function test, we do first TSH. If TSH is high, then we do T3 and T4, but that means hypothyroidism may be there. And it is very, very common many a times in thyroid swellings and needs particular concern when it is subclinical. And whenever it is there, it can be conservatively treated with medicines and never undertreated. TSH, if raised, then antithyroid peroxidase must also be done because it indicates an autoimmune disorder in which it has to be monitored. And then patient has to be followed up for malignant change, especially if you are investigate for infertility. Hypothyroidism is very important to be investigated. If TSH is decreased and T3 and T4 levels are done very high, in this case also anti-TPO estimation is done. In case of hypothyroidism, then we go for thyroid scan. In hypothyroidism, no, but if it is hyperthyroidism, a thyroid scan or scintigram is done. A special point about hypothyroidism, in those cases, we have to investigate the patient for diabetes, mellitus, and features of metabolic syndrome, because hypothyroidism and diabetes together may lead to various CVS complications. So after doing thyroid hormones and having an idea about that, patient may be hypo, hyper, or euthyroid, then it's an important investigation is ultrasonography. In case of all thyroid swellings, ultrasonography is a very important investigation, but it is to be understood that it is not a screening tool in general population. Ultrasound is indicated when a thyroid is clinically palpable. And how does it help? It helps us to know many things about the thyroid swelling and also in deciding the most suitable area for cytological aspiration. Suppose it is nodular, single nodule, then it is from the nodule. If they're multiple, then from the most dominant nodule. So it helps in deciding the suitable area for cytological aspiration. Many a times, if FNAC is done without doing ultrasound, just by palpation, it may not give good results. So it is best to do FNAC after doing ultrasound. And USG tells us about size, thyroid swelling, what is the shape, then ecostructure of the nodule itself, then ecogenicity of the nodule in relation to the surrounding thyroid and surrounding other structures, vascularity of the nodule, consistency, its relation to the surrounding structures like vessels, muscles, trachea, any calcification, whether microcalcification, macrocalcification, whether it is rim calcification, then elastography, compressibility of a swelling when it is pressed with the probe of the ultrasound elastography. Then halo around the swelling and how are the margins, whether they are regular or irregular. And if ultrasound is reported under these headings by an expert ultrasonologist, it is of great help in further planning for FNAC and further management. And these days, ultrasound, whenever ultrasound is done, there are several methods of predicting the possibility of, or what is the possible pathology, what may be the possible pathology of that thyroid swelling. And depending on that, we have developed a system. We means this is from ACR, American College of Radiology. They have developed a system which is known as ThyRaDS, and this is thyroid imaging, reporting, and data systems. So whatever characteristics of thyroid swelling or nodule we have discussed, they are all taken into consideration. And depending on that, thyroid 1, thyroid 2, thyroid 3, thyroid 4, and thyroid 5, they are decided. So benign, nothing required. If it is thyroid 2, score is 2, no FNA is required. If it is thyroid 3, score is 3, is mildly suspicious, you can keep the patient on follow-up. If it's thyroid 4, score is 4 to 6, is a moderately suspicious, the nodule is 1 centimeter or more, follow-up. If it is 1.5 centimeter or more, FNA is done, and a regular follow-ups are done. In thyroid 5, it is the score is more than 7, it is highly suspicious, FNAC can be done, or if follow-up is done, the very intensive follow-up is done. Similarly, the thyroids are also decided by American Thyroid Association, and they also divided it in. And the characteristics of the thyroid nodule on ultrasonography are basically the same. They are just compiled in a different way. And this is quack thyroids by American Thyroid Association. This is quack thyroids, and this is thyroids 1, which is considered normal. That is no abnormal pathology. Like consistency hard, margins irregular, vascularity more, then it is vascularity more. Then the thyroid score will be higher, and there will be more, it will be more suspicious of a malignancy, and a more active treatment will be required. Like thyroid 3, here it says no suspicious features. In thyroid 4, they are having 1 suspicion feature, 4B 2 suspicious features, 4C3 suspicious features. In thyroid 5, there are 5 suspicious. It's highly suspicious, and an aggressive or more active treatment is required. Then American Thyroid, they also divided based on the same characteristics. They have divided the nodules into high suspicion, intermediate, low, and very low suspicion. Then this ultrasound along with elastography and color Doppler, they are also have a scoring system, and depending on these scoring system, they predict whether there is a possibility of malignancy in the nodule or not. And they have devised certain positive predictive scores, like most important positive characteristic with elastography score and pathologically altered lymph nodes are there. And by then these scores are added, and then they divide, then they tell us whether it is, what is the prediction of being a malignancy. These are the points of a negative predictive score. It is purely cystic, if it is spongiform, and halo is complete halo, only peripheral vascularity, these are negative ones, and a low suspicion of malignancy is there. So this is what, if the score is less than 3, low risk. If the score is between 3 and 6, then intermediate risk. If the score is more than 6, then it is high risk. And risk of malignancy percentage is 2.4 in low, 18% in intermediate, and 79.6% high risk in more than 6. This is another classification like thyroids only, British Thyroid by British Thyroid Association, and they divide it in U1, U2, U3, U4, U5, and U5 is malignant. So what I mean to say that the different scoring systems from the characteristics which are seen on ultrasound, and main aim is to predict possibility or probable possibility of being it malignant or not. Then I said that in hypothyroidism, scan will be done, radioactive iodine scan will be done. And in that case, we see for what is the take-up of radioactive iodine by the thyroid tissue. If a nodule is there, then we see whether nodule is more actively taking up iodine than the rest of the thyroid, or the rest of the thyroid is more active. This relation is seen. And by this, we can decide about the treatment also, because suppose there's a nodule is there, solitary nodule is there, and in hypothyroidism, we do a radioactive iodine. And if that is a toxic adenoma, then we can do hemithyroidectomy in that case as a treatment. So radioactive iodine is, the scan is done in hypothyroidism cases. After we do FNAC, so I told you that ultrasound gives a good idea, fairly good idea where to take FNAC from. And for this also we have a classification which is given by Bethesda classification. And depending on the cytology characteristics of the aspirate, then they decide that what is the category and possibility of malignancy. Bethesda 1 is completely non-diagnostic, and that is in case of inadequate aspirate, only 1 to 4% chances of being malignant. In benign, 0 to 3, no characteristics suggestive of malignancy. Simple follicular structure of maybe in colloid goiter. Then third is atypia, a follicular lesion of undetermined significance. This will be better told in detail by pathologist, or we can go and study. And here the chances of being malignant are 5 to 15%. Bethesda 4 category is follicular neoplasm or suspicion of follicular neoplasm. Chances of being malignant are 15 to 30%. Then category 5 is suspicious of malignancy. Chances of malignancy 60 to 75%. And 6th category is malignant. Chances of malignancy are 97 to 99%. So this usually now whenever pathologists report and they give the Bethesda category, so thyroid along with Bethesda taken together, combined, they can fairly guide us what to do next and how to proceed. Here one slide I have kept is in Bethesda, the problem is with category 3 and 4, because these nodules are called as indeterminate nodules. And often the clinician is confused because they're indeterminate. They may be malignancy, they may not be malignancy. These patients often land into thyroidectomy and many a times mostly come out to be benign, meaning the rate of malignancy ranges from 8 to 56%. And therefore, this is the most difficult group of thyroid disease or thyroid nodular disease where there's a suspicion of malignancy, but we are not sure about it. So what to do? And for this, molecular studies are done, which can tell us about the mutations, the genetic alterations, which are shown to be responsible for causing malignant changes, and the treatment can be accordingly. And if we have molecular studies, if we can do biological molecular studies and can know the genes which are responsible, this may help in avoiding undue surgeries, but may help in having a targeted therapy for these patients, So after doing FNAC, a good Bethesda classification, followed or preceded by ultrasound, along with hormone estimation, these form the triad of investigation, which are the main and most important 3 investigations. After doing all 3 investigations, we can decide further course. But no one investigation is to be taken. They are taken combined and taken together. So if the patient is having only problems in thyroid hormones, hypothyroidism or hyper, we can give medical treatment. We should treat hypothyroidism optimally with the combination of both T3, giving T3 and T4. And literature says that it can be given IV, subcutaneous, intramuscular, but we have tablets, Celltoxin tablets. It's basically we start with a lower dose and keep on monitoring the thyroid levels. Thyroid transplant has also been described in history, but that is not basically now done. And then we have hopes from stem cell therapy. In hyperthyroidism also, antithyroid drugs can be given. Radioactive iodine ablation can be done of a hypothyroid nodule. Surgery is done in these cases if there's a toxic adenoma, which we can know from radioactive iodine scan, or uncontrolled Graves' disease, in which after optimizing the thyroid levels, we can do surgery. There is a role of antithyroid antibodies in both hypothyroidism as well as hyperthyroidism. You know, what is the role of surgery in thyroid conditions or thyroid nodules? Whenever there is a multinodular or solitary nodules are having more chances of being malignant. The evaluation and the investigations are same. Then we do FNAC, and depending on that, we decide. An absolute indication for thyroid surgery is malignancy. And the malignancies which are common in thyroid, they are divided into well-differentiated carcinomas and poorly differentiated carcinomas and anaplastic carcinoma. Well-differentiated, we have follicular carcinoma, papillary carcinoma, Hudson cell carcinoma. Then there's a poorly differentiated and anaplastic. Anaplastic is so fast growing and aggressive that hardly ever a patient lives 1 year after the diagnosis. And non-malignant conditions for thyroid surgery are huge thyroids which are causing compression symptoms. Compressing on the trachea, compressing on the esophagus, then on the recurrent laryngeal nerve, causing vocal cord paralysis, or it's such a big thyroid tumor that it causes cosmetic problems and patient wants for that. Or Graves' disease. These are the non-malignant conditions in which thyroidectomy or thyroid surgery is indicated. So this I've already told you, differentiated cancers, and they are PTC, follicular thyroid carcinoma, Hurther cell, and the surgery which is done may be hemithyroidectomy. In case if it is a malignant like papillary thyroid carcinoma or follicular, it comes out, then a completion is done. But if you are very definite about the diagnosis, malignancy is confirmed, then total thyroidectomy is done. But sometimes what happens is that by depending on the FNAC report, we do a hemithyroidectomy, and if it comes out, they confirm it to be a malignancy, then sometimes completion thyroidectomy is done after hemithyroidectomy. And this may be a hemithyroidectomy, this may be a total thyroidectomy, or hemi, then followed by completion with or without neck dissection. Because in papillary thyroid carcinoma, lymphatic metastasis in the neck in the level 4 and sometimes level 4, in the level 6, that is central compartment, and sometimes in the level 4 and 5 are seen, and in those cases, neck dissection may be required. The similar things can happen in follicular, but in follicular, the other metastases are there, neck metastases, they are more common in papillary thyroid carcinoma. Hurther cell carcinoma is another variety, and because during today's talk, we cannot have detailed discussion about the surgical part. I will just give an outline about it. Thyroidectomy is usually done by, this is an open thyroidectomy which was done and still being done. Focus incision was, initially it was a big incision, but now we can do it with a reduced or a smaller incision. And now there is also evolution of minimally invasive techniques or very small incision. Everybody can hear me?
Yes, we can. Please
Yeah,
continue.
okay. So coccus incision, and then in case of anaplastic, after doing total thyroidectomy, because it is an aggressive one, there is also role of targeted therapy. And targeted therapy can be decided after doing molecular studies. Then besides open thyroidectomy, there are other surgical approaches which are in vogue now, and they are MIVET, robotic, radiofrequency, which is not very popular. MIVET is basically micro-invasive, minimally invasive video-assisted thyroidectomy and thyroidectomy by robotic procedures. So what is this minimally invasive video-assisted thyroidectomy? It was developed by Mikoli. The incision is above the sternum, just 2 centimeters above the sternal notch. But it is only 1.5 centimeters. From there, a tunnel is developed. 5 millimeter endoscope is inserted, 30-degree, and dissection proceeds by separating the thyroid log from pre-thyroid muscles. This is also the procedure which is done in open thyroidectomy, but here we do it through endoscope. The steps are same, but the benefit is there that they say that no drain is being used and osmosis is naturally good. And these approaches, the alternative approaches, have been developed just for osmosis. Though there may be other benefits also which are comparable, but osmosis is certainly better. Bigger thyroids, more than 35 millimeters, or thyroid volume not more than 25, and they are not good candidates for this. For this, then there is a separate method. Axillary incision is used and the plane is developed. Anterior chest wall approach is there. In anterior chest wall approach, we have two ABBA or BABA. Both these mean bilateral axillo-breast approach. And this is anterior chest wall approach. Again, 4 tunnels are developed. Dissection is done via endoscope or by robot. There are 2 methods. And thyroid is dissected. Maximum diameter of thyroid which has been removed by this approach is about 11 centimeters. Now we'll have some idea about these approaches in short. Besides the ABBA approach or the MIVET approach, minimally invasive video assisted, some people also describe a transaxillary and a retroauricular facelift incision. Behind the ear, through this incision, again we create a tunnel to reach the thyroid on the same side where we give incision and we dissect the thyroid. Then another approach, alternative approach, is through the vestibule of the mouth, transoral, between the teeth and the lip. Again, we create a tunnel and we reach the thyroid and we dissect the thyroid. And robotic system uses Da Vinci. This procedure was initially described by Kang et al. In 2007. In this case, there's a special setting of the workspace, docking by robot, and the surgeon works on the console. Now this is about retroauricular approach. This is the patient, and this is the right, on the right side incision is there, and the size, this is showing the size of the flap raised by retroauricular incision, and we will be able to reach the thyroid on the same side, and we'll be able to dissect it. Steps are same. The benefit, which is obvious in this case, is that of scar or cosmesis. So this is the incision, and this is how we create our tunnel. We can introduce our endoscope, and we can introduce the instruments, and on the monitor we can see and operate. We can directly operate through the endoscope. This is ABBA or BABA. The 4 ports are developed. 2 ports are in the circumareolar area. These are the 2 ports in the circumareolar area. And the 2 ports are in the anterior part of the axilla. This is one, and this is another. One of the ports is bigger, 1.2 centimeter. This is 0.8 centimeter, and axillary are also 0.8 and 0.8 centimeter. The bigger one is used for camera port. This is a camera port. Then docking of this. Now we can use an endoscope through this. The same approach, we can use an endoscope or robotic. If we're using endoscope, we can introduce an endoscope through this, and or we dock the robotic station, and we can use the robot where the person, the surgeon, sits on the console. And instrumentation can be done from these ports. These points, they show you the various landmarks on the neck and the chest, which are to be first marked before doing surgery. When we develop ports, we develop tunnels from here, from here, from here, and we can see on the thyroid bed and work over it. Again, I'm telling the steps are same. Superior thyroid vessels, inferior thyroid artery, middle thyroid vein, recurrent laryngeal nerve, they are all to be taken care of or addressed as we address in the open or conventional thyroidectomy. Now, this is how we put different instruments through an endoscopes through different ports. And the endoscope is 5 millimeter and 10 millimeter, which is to be used. This illuminates this whole area, and you can dissect. Now, there was then a comparison was done between various techniques. They say learning curve is shorter, about 30 to 35 cases after that. The time was less, complications were comparable, pain was less and minimally invasive. Cost considerations or cost is considerably high in all these minimally invasive robotic or endoscopic techniques. So they are minimally invasive, but they may be maximally expensive. Radio frequency was used by somebody to take care of small autonomously functional thyroid nodules, but this is not being done. I'm just telling you the option. Then there was a paper where they say there's a regression of a papillary thyroid cancer, small papillary thyroid cancer using metformin, but more studies are required. This was published in Annals of Thyroid. So what take-home message is that advancements will continue, because in the beginning we're doing with focus incision, a big incision. Advancements, we know they are better, but a proper comprehensive evaluation, not ignoring the conventional methodologies. And the best is to thus selecting the most suitable candidate for any new trial, not forgetting the cost factor in Indian settings. And the most important thing about this is the thyroid cancer, which we are all mostly scared of, but it is an indolent, slow growing tumor, and therefore we should not be aggressive by its treatment. So it is being indolent and aggression may not be needed. Thank you. I want to open the chat box. Slide 9. Okay. One, two, three, four, 5, 6, 7, 8, and 9. Yes. You want to ask about this? Hello?
Yes, Dr. Uma.
Any questions?
Yes, there are a few questions in the
Oh,
chat
how
box.
to go to chat box? Just tell me
Uh,
again. Yeah.
Now, can you
Yeah,
see the options at
I've
the
got the
right
chat
bottom?
box.
So, dear
In Fullerton
trainees, you may
sign
type your
test for
questions,
hollow.
comments in the
At
chat
least
box.
the
Yes.
hands should be raised for 1 minute at least, and then only you will be able to see the flashing of face or engorgement of vessels on the upper part of the neck or the neck. Coccus incision is 2 fingers from the sternal notch, above the sternal notch. It's an horizontal incision, and the lateral limits are medial borders of sternocleidomastoid muscle. Slide 9, I've actually showed you. That was because there are different methods of scoring for the characteristics found in ultrasonography, and there are different scoring systems to predict the possibility of swelling being malignant or non-malignant. Role of Doppler is to know the vascularity. Otolaryngology clinics of North America, which is one of the clinics, is on ultrasound of the neck itself. That has described 5 types of vascularity in the nodules in the thyroid. They say if they can be perinodular only, it can be on the periphery mainly and less in the center. It can be in the center, more, less on the periphery, or only central. So depending on that, as the vascularity changes, or if the vascularity is more in the center or in the center only, then the chances of the nodule being malignant are more because of angiogenesis. So a good ultrasound or a Doppler helps us to know about the vascularity of the nodule. And that helps us to know the exact score of that nodular lesion. Any other questions? Okay, role of Doppler from your post privately. How to manage case of acute thyroiditis. Acute thyroiditis, as the name is indicated, signs and symptoms of inflammation may be there. There may be a swelling in the thyroid, which may be diffuse, and it may be tender, history of fever, and the treatment is conservative by giving antibiotics and other supportive treatment. Near total thyroidectomies. Yes, I told you about hemi and total, but basically the Thyroid surgery, the range is from a nodule excision only, which is not done now, to a hemithyroidectomy, to subtotal thyroidectomy, near total thyroidectomy, and then total thyroidectomy, and then thyroidectomy with neck dissection. Near total, you just leave a 5 gram or a small piece of thyroid. That is near total thyroidectomy, but that is usually not advocated. It is either a hemi or a total. Papillary carcinoma treatment of choice, it is basically surgery and yes, total, because in papillary carcinoma, it may be multifocal, so other lobe may be involved, and then there is also lymph node involvement, so total thyroidectomy with central compartment clearance. But there is a different schools of thought about a micropapillary or a small papillary carcinoma, because every case of thyroid cancer, especially when we are talking about papillary carcinoma, they have to be evaluated individually, because there are certain factors which will again point towards a high risk or a low risk disease. Suppose there's a small papillary carcinoma, age of the patient is less, there are no lymph nodes, the other lobe is not showing any indication of any node or any lesion. In my opinion, there's always has been a discussion on this in these cases. We can do a hemithyroidectomy and keep the patient on an intensive or extensive or a close follow-up, which is by ultrasounds. If any suspicious lesion arrives by FNAC, by thyroglobulins. Again, I'm saying this, you don't have to be aggressive, because these tumors take years to develop sometimes, except in anaplastic, which is very fast growing and aggressive. In my talk, I forgot to mention about medullary thyroid carcinoma, which arises in parafollicular cells. And in that case, also total thyroidectomy is done along with neck dissection. Hello, is Dr. Nilima here?
Yes, ma'am. Hello.
Anything? It is, the next question is full form of, yes. It is axillo breast bilateral breast approach or bilateral axillo breast approach. So here we are not doing anything, but these are the approaches which are being done in Europe and in some parts of US also. And this is just for, I think, cosmesis. But yes, they say that pain and certain the chances of incidence of recurrent laryngeal nerve injury and protection of thyroid, saving parathyroids, they are almost comparable. So we need more studies to say that whether this should be done or not, if they are available to us. Recurrent papillary carcinoma management, the guidelines are same. First, you have to investigate by same way, ultrasound, FNAC. Recurrent will be there if you've done a thyroidectomy in the other lobe. Recurrence may be local nodes, so that will need surgery only. But a small one can be, again, there are two schools of thought, and there's often a discussion between, especially between surgeons and ENT surgeons, that why not to ablate with radioactive iodine small cancers, which may be recurrent also. And that applies to recurrent also. Metastatic Papillary depends if they are lymph nodes, then surgery, but we always take patient in confidence. Radioactive iodine can also be used if the tumor is iodine avid, and that is decided by thyroglobulin estimation, which is also one of the methods for follow-up or intensive follow-up in operated cases of thyroid cancer. Surgical management indications of surgery in thyroid. Uncontrolled Graves' disease after optimizing is the main indication. If you're not able to control, eye signs are there, then it is surgery is indicated, and the surgery is the procedure is same. We do the same way as thyroidectomy is done, but bleeding may be more, and there may be chances of having a thyroid storm in post-operative period. So it is total thyroidectomy only.
I think, ma'am, so many questions about the management they have asked, and
I think about the management part,
yeah.
we can have, if all agree, separate or another lecture or talk, because it's management, surgical management especially, is very, very important, and it was not possible to cover the whole thing in one talk. So
Yes.
evaluation is equally, and what I think is more important than the surgical management part, and therefore I try to cover the things in evaluation, which is very, very important. It should be step by step, combining all the modalities, and then you decide what to do. Right?
Yes, ma'am. Because history and examination are equally important. They get a case in their exam,
Yeah.
and so evaluation of the swelling, they have to be really good at that. And
Yeah.
then next come the management.
Anything else? How long we have follow-up of a post-road for papillary carcinoma? For papillary, as well as for other thyroid cancers, the follow-up is usually lifelong. First thing, they are slow growing, indolent, and so till the patient lives, a definite follow-up is there every 6 months or 1 year. And the methods of follow-up are same, either do thyroglobulin, do a ultrasound. If you're suspecting metastasis, then do other scans, a PET scan. The follow-up is to be lifelong, because we have seen a case of recurrent papillary carcinoma after 30 years. Though 30 years back, and now it has been since 10 years also, I think I saw this case. She was operated 30 years from then. But at that time, she was not sure whether it was cancer or not. And there was a papillary carcinoma in the other lobe. Hemithyroidectomy was done. Then after total thyroidectomy, we also subjected the patient for radioactive iodine ablation. So long follow-up, rather lifelong.
I think there are no more questions in the chat box.
No more questions? Yeah, no more questions are there in the chat box. I think we have completed all the questions.
Yes,
Yes.
yes, Dr. Uma, thank you very much, Professor Dr. Uma Garg, for the presentation, and thank you very much, Professor Dr. Nilima Gupta, for joining us. And thank you, trainees and faculty members, for joining.
You're welcome.
Thank you, Mr. Navneet.
Okay.